what harm is
We're starting the recording, but please continue on. People will enjoy the
Oh, we'll
passionate
start babbling the whole time. So,
talks.
oh yeah, other
Dr.
people are involved.
Calhoun. We're going to give everybody a few minutes to get here.
All right.
Now, if you're just coming in, we are already having such a wonderful discussion here before we started the webinar. I can't wait for you guys to hear from our esteemed guest. And I would love it if you guys wanted to introduce yourselves in the chat. This really helps all of us see the real breadth that we have in the Her Plan Network, because we have so many states now. We're up to a directory in 25 states with over 2,800 service locations, including virtual home visit and office resources. And then we have so many different categories of care. So if you would put your name and organization and website and state, name, org, website, state, I'll put that in, or some variant thereof, that would be so helpful. Welcome, Deborah. Welcome, everybody. I love seeing the chat and seeing the different kinds of care providers interested in this important issue. Oh, yes, adoption. Adoption is an important part of the conversation for families that feel ill-equipped to care for children with special needs. I think Lifeline just started a new page for special needs adoption, actually. I'll pull that up for the wrap-up email.
There's a great organization I've worked with for many years, dear friends that are actually in Idaho, called Nathan, which is for national group of people for children that are homeschooled. And actually they have a organization called Nathan Chask. And what they do is they will adopt any children with any needs. They have families available to do that, and they will offer help and assistance for taking care of children with special needs or, limited life, whatever you want to call it. Or both, and they will actually help arrange families and assistance for the families to be able to take care of their children and or help adopt them out if they don't feel they're able to provide that resources. So they're really, really good people. I've known them for many years. They're they're in Idaho.
Well, Dr. Calhoun, you're going to have to connect me, because I've been trying for 2 years to get a good connection with that group. I'm glad we have these calls. So as everybody's going around introducing themselves in the chat, I just want to mention that at any time in the presentation, you can use the chat or the Q&A box to ask questions, and then I will moderate those at the end. So I'm going to pull up the Her Plan directory. And some of you know by now that we have switched to a cluster format on the map, which is very exciting because you can kind of see summaries of regions and how populated our resources are. I want to mention that I encourage all of you who are assistance providers, which is most people on the Power Lunch calls, to go ahead and check and make sure your organization is listed on the map. It may be that you received this invite because you registered to be on the directory, but we actually can't post some of you until we complete a compliance process. And that's different for each individual provider. So for example, this is abortion recovery. So before we were able to post this provider, we go through the qualifications and curriculum of those offering different, in this case, counseling and abortion recovery services. So it may be that you've registered for our directory, but you haven't completed compliance to actually be posted. So I just wanted to remind everybody to please go find yourself on our map. And if you can't find yourself, please email me at info@herplan.org. I'll put that in the chat, so that it's really, really imperative to us to get you guys listed as quickly as possible. Let me put that in the chat here. info@herplan.org comes straight to me. And then since we're on prenatal diagnosis this month for our Power Lunch, I want to show you how many prenatal diagnosis resources we currently have in the areas of disability, medical interventions for baby, and perinatal hospice. So we are very upset that this is one of our most underserved categories of care. So I highly, highly recommend, if you know of an org, like Dr. Calhoun just said, an org that helps with anything special needs related. Maybe it's a Sunday school in your area that has a special needs ministry, or a special needs support group at a church, or a NICU support group, or a perinatal hospice at a hospital that you know of. Please, please, please we need more resources in this category of care. You can see we only have, let's see if we load all, if it loads anymore. There's only 58 resources for these 3 subcategories across our 25 states. So we definitely want to improve that. So please do go ahead and send me your recommendations. And then finally, before we get started, I want to remind all of you to create a user account to use the platform. So you would simply go here on the map, directory.herplan.org, accessible online to anyone. And then if you go to the sign up bar, that brings you to directory.herplan.org/register. And so those of you that provide direct services, that's what it means to be a provider user. So you're going to go ahead and register as a provider user, putting in whatever your salutation should be. That's often the name you want to appear in emails to you or appear on the map. Your first and last name, your job title, your organization, how you heard about us, if you remember, and then at the very least, your city, state, and zip, and then an email and a password. And what this allows us to do is grant you a user account. So I will log in just as my general user account to show you some of the really cool features that are there. So once you have a user account, it actually allows you to save your favorites. So you can go to save searches. You can see here that I have saved health and well-being resources in Georgia, a category 1. You can date them, you can name them whatever you want, and then you can open them. And when you open them back up, that actually gives you access to a live version of these filters. So if when I saved the list, there were less resources, and now I'm opening it up again, I now see any updates in live time to my saved searches. And then I can also add new filters, and I can save the entire search by clicking the button here. And then you can also save individual providers. So if you really like a provider, you go to their provider profile page, you can actually add them to a list. You can also print them out and share them. And if you share them, that's a unique URL. So that actually doesn't require a login for the person that is viewing that URL. You can just send that to anyone. And then if I go to provider lists here are all my lists. And again, I can share or print the providers and edit them. So it's just really important to all of us that you guys know the full features of HerPlan. And I would love it if you email me again, info@herplan.org, to recommend providers to make sure you're listed on the map. And then also if you'd like to request any user how-to videos that we have for training on the use of the directory, if you'd like a refresher and a little bit more details about some of the features I just showed you. So just a reminder to please go ahead and check out our directory.herplan.org site. And with that, we get to the very excitement that we are not just a directory, we are also a wonderful network of providers that seek to encourage one another and teach one another. And though HerPlan is not the expert, we want to be the expert at who the experts are. And today I am bringing you 2 experts in the field of prenatal diagnosis, Dr. Calhoun and Dr. Robin Pierucci. So we are absolutely honored to have them, and we will turn things over to Dr. Calhoun first, who's really known as the pioneer of perinatal hospice, and I'll be sharing some of his slides for his presentation. Can you see that okay?
I can see it.
Perfect.
Are you moving my slides for me?
Definitely. Yes, I can certainly do that.
That's I thought I would do a real sort of a broad sweep or broad overview about perinatal hospice, because my job, of course, is prenatal diagnosis. I do maternal fetal medicine, so I do with all the high risk obstetrics. So the referrals to me are for people who have complicated diagnosis, the intrauterine either anomalies or just different things, different diagnosis. And so that's sort of how I got into the hospice idea, basically to provide alternatives to people who had babies that they had an adverse prenatal diagnosis, either one that was life-limiting or one that necessitated further referral to other fetal therapy or fetal treatments. But we're going to talk a little bit more, focus more on the hospice thing, since that seemed to be the tasking that we had. So why don't we go to the next slide? So what we're going to talk about is basically looking at a model for families with an adverse prenatal diagnosis, and we'll try to talk a little bit about that and get some ideas. And obviously, if there are questions, either I guess save them for the end, or we can talk about them as we go, however you all want to do it. But we'll go to the next slide then. Well, basically, a lot of this was before we had ultrasound and we had a lot of the things we have technologically now. There was a really hard ability to diagnose fetal anomalies or adverse prenatal diagnosis, and birth defects are still the leading cause of neonatal death in the United States if you look beyond prematurity. And so the incidence is about 2.2 to 0.3%. So there's 6,000 to 10,000 or more of these babies every year, and that really hasn't changed from 2001 or 2002. It stayed pretty stable, or pretty much reported out the same thing every year. You want to go to the next slide? So before this was developed, and I was involved in this many, many years ago, the idea was an intentional desire to do particularly abortions to spare moms and families the whole idea of this distressing experience, if you will, and get it over with. Obstetricians tend to be surgeon-like and want to do something and want to deal with their patients and get over their discomfort, a lot of them with bereaved patients. And I think they also thought they were going to avoid maternal complications of pregnancy and childbirth, which really isn't true. Generally, when these are diagnosed, you're already at the point where you're going to have to do either a surgical procedure or actual delivery of the baby. So you're not going to really avoid that part of the whole sequence of childbirth and of pregnancy. Increased fear of maternal mortality, which really isn't true. And then I think there's really still isn't a real bias against anybody who's not perfect, whatever that means. I have 6 children. I don't think there's any perfect child that I'm aware of. Maybe some of you have the perfect child, but I myself have never found that to be true. Next slide. So when we looked at termination and we looked at spontaneous loss, there's some couple slides I'm going to show some of just a little bit of the real data about this. If you look at 23 women who had terminations of pregnancy for anomalies, their grief responses at 2 months were significant. You saw major depression, and a significant number of these patients had sought psychiatric counseling for major depression or post-traumatic stress disorders or other things that were related to the termination of the pregnancy. Next slide, if you would, please. There's a much larger group looking in the Netherlands who has really good data. They looked at about 250 women, and they looked at way beyond the actual initial grief response. And what they found was up to 3% of these patients had really pathological grief, and that 33% or 33 of these patients, or 17%, actually had post-traumatic stress. So this isn't something that people just get over. So you terminating a pregnancy or doing an abortion doesn't solve this problem that you thought you were going to solve in terms of depression and intense grief responses and post-traumatic stress disorder. Next slide. Even looking at anencephaly, which is a lethal anomaly, there's no cranium or brain bone, or there's just basically no covering over the fetal brain itself. And they looked at about 160 women with their male partners, and this was done and looking at perinatal grief scales and looking at impact on life scales and looking at depression inventories. Go ahead, next slide. And what they found is that women who chose to carry their children with anencephaly, even though this is a lethal anomaly, had less despair. There was less avoidance after their hospice experience, and much decreased levels of depression compared to those women who chose to terminate pregnancies. So in terms of the health of the moms and their families, it was better to do the hospice care than it was to do terminations of pregnancy. And like I've said before, my father talked a lot about, if you have a hammer, everything's a nail. If you don't have the ability to offer people good perinatal care and good follow-up through hospice, then you really don't have anything else to offer anybody. So it's critically important to be able to understand this should be offered and at least addressed with patients who, most of which you don't want to terminate their pregnancies anyway. Next slide. Looking at this, we can document this, and this really hasn't changed a whole lot. They found that 20% of patients will continue their pregnancy no matter what. I did a couple of small studies, one when I was in the military and one outside of the military in more civilian group. And we found between 75 and 85% of patients would rather carry their babies and love their children and be able to be parents versus doing a termination of pregnancy if actually offered the support of a hospice group. Next slide. Also, they talked a lot about mortality rates, and this is very interesting discussion because if you look at mortality, we don't do a really good job in this country anyway of collecting statistics, and they tried to show that, you know, the mortality rates from abortion was about 10 per 100,000 at 16 to 20 weeks when we find most of these babies with the problems. And they talked about the maternal mortality. Later, they said was about 17 per 100,000 for live birth. Next slide. However, if you looked at the data carefully, only 50 to 70% of maternal mortality deaths were actually pregnant. So if you look at the data, it's really bad. When they went back and looked at certain subsets of patients and they said, were they even pregnant when they had a mortality that was supposedly a maternal mortality, 70% were pregnant in one study, but only half in another study. So you can't really say that you're going to have increased maternal mortality because you let somebody go on and continue their pregnancy and do hospice versus looking at the terminations of pregnancy, because the data is extremely flawed. And we know that the maternal health, mental health effects are significantly much worse in patients who actually do terminations of pregnancies. Next slide. So a little bit about the hospice, and just to sort of try to set the stage a little bit and then talk about it later a little bit more here. Adult hospice began back in the 1960s in Britain with Cecily Saunders, who was actually was a nurse and actually was a social worker. And what really people feared in terminal diagnosis or diagnosis in hospice was that there's medical nursing issues with the comfort of the patients. And there was a common fear that was pain involved, and people worry about the baby feeling pain. And in utero, we know that for the most part, these children are not feeling pain. They are safe and within inside their mother's womb, and that they're not suffering, if you will, in utero. And then we're going to have Dr. Pierucci is going to talk about the things we can do after delivery, just like we did for other people in terms of addressing the pain. And the withdrawal from these families is what they really don't want. They don't want to be abandoned. So it provides a helpful framework for us to talk about, you know, how to family-centered care of patients who have children who have an adverse diagnosis. Next slide. So perinatal hospice is the prenatal diagnosis of a terminally ill fetus, and I try to use terminally ill as much as possible in utero, leading to hospice as a part of the continuation of the end of life care. In other words, compassionate care, suffering with our patients, and providing the things we can do, which are a lot in terms of the pregnancy, dealing with the loss of a child. Next slide. So for us, it's a very comprehensive care, and it's multidisciplinary. We talk about the emotional needs of our patients with mental health professionals and with our social services. We also have chaplains involved here. We have, again, our mental health people involved. We have our sonographers, our physicians. We have residents and students. We have nursing students, ultrasonographers are all involved in providing the comprehensive care. And it's a care for the entire family, involving, you know, mother and dads and any other family members, grandparents, if they need, other people who are involved, children even, that they have involved in this. So it's multidisciplinary, and we try to coordinate this as much as possible so we have a good plan of care put together. We develop birthing plans and other things to really help the patients think about and guide the care that they want, so that we're helping them through the time. We're suffering with them. We're not trying to short circuit or trying to devaluate the life of their child for however long that may be. Next slide, please. So basically, it's not high tech, it's very high touch, if you will. Once we have a good, solid diagnosis, we offer accessibility and support, a reassurance that the moms are not going to be harmed by this, that they're going to be able to continue through the pregnancy and not be harmed by this, and that their family will be able to work through this time of real disappointment and loss of what they see as their expectations for this child. And I always tell people that suffering with people is compassionate. It's compassion is the idea of suffering with or walking with somebody. And then we provide it as a stated, well thought out alternative for the patients. Again, if you don't have a plan, you can't beat something with nothing. You have to offer somebody a plan or something to help them work through this. And I think that's really key in this whole discussion. Next slide. We involve my perinatologist like myself. I involve our neonatologists. We make sure that they have the birthing plan. We make sure that if patients want to meet these, our physicians, they get a chance to meet them. They meet the residents and physicians. We have fellows and students, sonographers, nursing, all the people that would be necessary that would touch them in this process, and that we would offer them anything they would need to work through this. We usually have them deliver. We offer opportunities for mementos. We offer moles. We offer as much time as they would like to have with their baby. We offer them the opportunity to be able to have burial services and other things that would be necessary. We usually do follow-up at a week and a month, and then sometimes monthly, in certain cases up to a year after the loss of their child, to help them understand that we really do value them as our patients and value their child's life. Next slide, please. So from what we found when I did this is that the families had opportunities with siblings and family members to spend life with the child. And I have often said that, talk about a lot about quality of life. Now that's a lot of things that is bandied about. And I've always said that I can think of nothing better than if you lived for 30 or 40 minutes, but that whole time you had nothing but love and time with your family. There was never a time that somebody wasn't holding you and loving you and caring for you. And it seems to me that would be the ultimate inequality of life. There's never a time in which someone was not there with you and loving you. You were not abandoned. The other thing that came about of this is a big side effect is the satisfaction for everybody who really, once you understood this, the buy-in was total, that everybody thought this is the way it should be done. We should be with our patients. We should offer the care. This is why we do medicine. This is why we do what we do. It also gives an opportunity for evaluation of the babies, confirm our diagnosis. Perinatal autopsies are important. Many times we'll find things that we did not see on ultrasound. Remember, that's black and white. It's not the real baby. So it gives us an opportunity to do the things we want to do and to help guide counseling for future pregnancies. Next slide. If you look at hospice at 2023, we talked a lot about organizations. The best one for this, for looking at perinatal hospice resources, is perinatalhospice.org. Amy Kubelbeck is a dear friend of mine, and she's put this together, and she has all the hospice programs listed, not just nationally, but internationally. And since we've introduced this, 25 years ago, this has expanded exponentially. There's, I think, over 300 programs now. I have 266, but there's over 300 programs now. There were like about 80 in 2010. It just keeps growing and growing and growing in terms of the effects and the outreach, the impact we're having on families and on physicians and healthcare. Next slide. That's the website. It's www.perinatalhospice.org. There's resources. There's family support groups for different diagnoses. There's lots of resources in terms of looking at how to do a birthing plan and how you would like your child to be dealt with and cared for. Just a plethora of resources on that website. Next slide. And for those of us who do this, I think the challenge is to really examine our motivations and responses. Why do we do what we do? Rethink how we take care of these most vulnerable of our patients, and try to provide an integrated care, so we don't get the stovepiping, as I call it, the pace where people just feel like they've only doing their thing, but working across the whole spectrum of care, from our sonographers and students to the physicians and families, and realize this isn't really necessarily for everybody. We tend to withdraw from painful situations, and so training is available for this. And I think if it's something that really interests you, that is out there, there's a lot of good resources now. And I think institutionally, we found that we need to break down the barriers, like we always should, but particularly in this particular group of patients. And it's nice to have some guidelines. I'm not a big person who says you do standard practices, because patients are all individuals, but at least have how to offer and ask the questions and to think about things that you should think about in caring for these patients that are unique to their particular situations. Next slide. So if there's questions, that's my office number and my email, and I'll be glad to, I've got resources if you want, I'll be glad to do emails or answer questions on my phone if that's something you're interested in. And I'll let Dr. Pierucci take over now. Unless there's a question you want me to answer.
Don't see any questions. If anybody has any questions for Dr. Calhoun, feel free to put them in the chat and the Q&A, and we'll go over every question at the end. Over to you, Dr. Pierucci.
Well, thank you for having me. And it is so wonderful to get to do this with Dr. Calhoun. So I'm a neonatologist. I get to meet these little ones, but I started doing perinatal palliative care back 100 years ago when it was new in the NICU. And we started talking about, well, wait a minute, a little humility, sports fans, we can't fix everything. So it really, with a sense of, yes, I can't solve every medical diagnosis, but that never absolves me of my absolute duty to care about these little guys and their parents and all of the family members that are part of these family units. So it was with a sense of, how do we organize this care? The palliative care movement had begun. It had started to reach pediatrics. And we said, well, come on into the NICU. And some of the studies that I had the privilege of being part of is we started looking at outcomes. And when we invited our palliative care friends, gosh, the babies, we had fewer deaths with CPR. We had more people asking, where would you like to go? So we got babies home when it was really important to be able to see other family members, especially for people who are traveling quite a distance to get to our hospital. How do we come home and give them the support? What entity, bringing pictures in, and all of the celebrations that are so important. Those became an essential part of now what has become a much more organized thing. Perinatal palliative care is not new anymore, and it's now become part of the landscape of how do we deliver excellent care that is absolutely wed with medical excellence, which is part of now my evolution in doing this has become a concern in the context of our current culture of imperfection is not a reason for abandonment. And I've started calling this fetal concerns because we also have the ability to diagnose stuff earlier and earlier and earlier. But at the same time, the predictive value can sometimes change. It used to be that prenatal screening was done on moms who were at risk. And a couple years ago, they changed that to all comers, which in statistical gibberish means you dropped your positive predictive value. And it's now, offered as early as 10 weeks, some of this prenatal screening. And sadly, when moms are at regular OB appointments, they often don't have people who are as open to the intrinsic value of life as we would hope. And I've started hearing moms come to me saying, how come all the doctors want to kill my baby? Which is heartbreaking. So we're trying to now create what I'm calling a fetal concerns clinic, where there's a way to call us to say, hey, we have a diagnosis, but one of my favorite things to do in my palliative care consults, or actually any perinatal consult, is say, congratulations, do you have a name for this little one? Because no other diagnoses ever negate the first diagnosis, which is, it's a baby. It's a little boy, it's a little girl. So now how do we care for this little one when we have additional diagnoses? And, Dr. Calhoun, so appropriately, pointed out, none of our children are perfect. If you have any of those, wow. But I'm kind of grateful that my mom could not see all of my defects on a fetal ultrasound, because I have a lot of imperfections. That's a problem. So, how we look at imperfect these days is a problem. And it's just not an excuse to get rid of the baby. It's also, once again, with back to that humility thing, I've had the privilege of sending home babies where families have been told the diagnosis is, quote, terminal. I don't even use that language anymore. We sometimes suspect there could be a life-limiting diagnosis, but I don't know where that limit is. And I try not to be a self-fulfilling prophecy, because we can make a lot of diagnoses come true sooner than later with that death thing by not doing for them. So I talk with family frequently about, let's let the baby decide. If the baby responds to treatment, then we're going to go one direction. If the baby doesn't respond, then we go a different direction. But it's all about, how do we care for this little one, not prolonging suffering. And trust me, I've been to deliveries where a resuscitation was not appropriate. So I am not saying you have to do everything all the time. Absolutely not. However, I think everyone deserves a chance at life. So now, how do we help for as long as we have that privilege to do so? And boy, me not having slides always risks the chance of me just blathering on forever. So if there's questions coming in, please go ahead and stop. I'm happy to take some of those, because it is so important that when you look at your centers, or even websites, people are doing amazing things with palliative care in general, but I think you need to ask the question, do you find life inherently valuable? Because not everybody does. We deal this with not just even imperfections, but just at the edge of viability, which has changed dramatically since I began doing this. We were chatting before this all started about, remember when, if a baby had to be put on a ventilator, there were nurses who kind of very quietly got out a death certificate because they didn't think the baby would survive. Now, I don't want to say routinely, because that makes it sound like it's a guarantee. No. But we often are intervening for babies who are at 22 weeks gestation. So almost just over halfway through a pregnancy. And we're not just intervening, we're sending them home healthier than we ever have before. And yet, if you show up in preterm labor at a hospital that has predetermined that they're not going to resuscitate babies at a certain gestational age, they're a self-fulfilling prophecy. You're right, that baby's not going to survive if you're at 22 weeks, but your hospital says, well, we don't resuscitate anyone at less than 24. And this is where campaigns to teach people about what you have, questions to ask when you come in the door. How do I get to somewhere who does? How do I say safe? How do we advocate for, please give the mom prenatal steroids, and then we'll come and transfer mom if she's safe. These are the questions that we need to be able to teach people to ask, in the same way that we need to be able to say, hey, prenatal testing is okay, but it's not something you automatically have to do. If the people who are caring for you are going to use it to browbeat you into, if we find anything wrong, then we're going to invite you to terminate. Because as is so beautifully pointed out earlier, terminating it's never good for the baby, and it's not really good for mom. So this, I love the phrase misplaced beneficence. This, oh, how do we just help you get past this? Doesn't really do that. In fact, it leaves often a wound that then we have to help later too, as well as the loss of the baby. So all of these things are part of fetal concerns that then if I need to put on my perinatal palliative care hat, because it becomes clear that, oh, I can't really solve some of these medical problems, but how do I help you live with them for as long as possible? Once again, palliative care is never about just do not care, the do not resuscitate. No, no, no. How do I help intervene when possible? Under palliative care, I have helped babies who have needed surgery to get home because they had an open abdominal wall defect. So we were able to close that. We couldn't fix some of the organs that didn't form very well, but we were able to help the baby go home so that the family could care for them within their arms. Antibiotics, treating infections that we know respond. This is all part and parcel of what we good. Palliative care is never an excuse for lack of medical excellence that we absolutely still get to do. It's part of my joy of doing this. And then walking with these families, so that they never feel abandoned, whether that's in the delivery room, whether that's during the pregnancy, as far as we get to go afterward. How do we hold someone's hand and say, no, this is rough? Oh, the other thing I know I wanted to mention, when we give parents a prenatal diagnosis, this is traumatic, and trauma-informed care is really something that is undersung in our own medical training, as well as what these parents are going through. They're traumatized, and all of the terror and the fear and the flight, all of those things, and PTSD are part of what these folks are going through. So gently walking with them as they mourn even the loss of a normal pregnancy, which they can't get back now. So, okay, how do we proceed? And how do I help them not be terrified about going out with the other kids or going out to dinner with each other? I mean, giving people permission, even if they have a baby that's very sick within the unit, please get outside air. I promise to call you if there's anything that can go on. So this is all part and parcel of this huge spectrum of, okay, we have a diagnosis. That's first, it's a baby. Now we have some other things to be concerned about. What do we do next? And please know you're not going to be abandoned when we do this together. So with that amount of babbling, I see Dr. Calhoun nodding. Did you want to chime in again?
No, I'm listening. I just is resonating just exactly what we've talked about. I mean, yeah.
So I noticed there's things going on in the chat, and I can't read and speak at the same time. I get dyslexic. So
it's a great comment from Deborah here about doctors wanting to, quote, kill their baby, and that's how women feel. And then the gaslighting that the medical community starts calling that compassionate care. And I just wondered if you wanted to comment on that, and the ideologies, the agendas. It can be overwhelming to try to build a culture of death and counter the culture of death with the culture of life that you're trying to build.
It is this. It's just the reality and the elephant in the room that there are entire obstetric organizations, and not just obstetrics, that talk about this. Somehow it's crept under the name healthcare, that you have to be able to intentionally destroy your baby. So my trying to sneak into the obstetrician's office under the guise of, no, wait, if you have someone who says, I want my child, then please stop browbeating them with feeling that you are somehow not doing your job by not offering them a termination at every single visit before and after. This is insanity. And by the way, I'll come with you and ask them not to do that anymore. So it is a reality. It is why all of you in the community are so important to walk with these people. Tracy Windsor, who's become a dear friend of mine with Be Not Afraid, actually offers training, and it's not just to medical people, it is to everyone. These are two moms that started this. They are brilliant. But how do we advocate for each other in the humanity that is part of this? I've been to a lot of deliveries. I've never seen anyone deliver a platypus or a table. Every single time you're pregnant, it's with a human baby. So, okay, how do we acknowledge truly the humanity that is intrinsic to all of us? We can behave less humane, but we're never not human. So the physiology of wanted babies is the same as unwanted. How do we help and offer a palm branch to our colleagues that says, now wait, what we get to walk with you. And if there is something I can't resolve, there's pathology I can't fix, okay, I still can do footprints. I can still, there's an organization called Lay Me Down to Sleep where they come in free of charge, take photos of the baby so that they have literally a treasury of a life, not just the remembrance of a death. We bring in our chaplains into the C-section room if necessary, as well as at the bedside to perform baptisms, and the videos of when that little tiny person is still moving are just treasured. Because they never stopped being parents. They had to then deal with a script that none of us would have chosen, but the people who walk through it, and we get to walk with them. I've never heard someone say, I'm sorry I didn't meet my baby. It is always with such gratitude that they say, oh, those couple days we had together were so wonderful. And by the way, they helped their other children not see this baby as a monster. They held their little one, they were with, and it stopped separating parents. And it was a much more normal grief process that included them, and it wasn't so scary than for the other siblings. So I've yet to see it not benefit the entire family, even when I can't solve the problems. It's still just such an incredible privilege to get to be part of this. And then every so often I get to be completely wrong and we send the baby home, and it's phenomenal to get to see those pictures. And that once again, I continue to have families that send Christmas cards and say, our life is so much better for us having the opportunity to care for this little one. And then this little one be the light of their lives, whether trisomy 13 or 18 or trisomy 21. By the way, the 13 and 18s, I was literally taught as a medical student that that's lethal. And the fact that we have studies of those children at 15 years of age, at 20 years of age, the only thing I found is that we're self-fulfilling prophecy. If you don't do for them, yep, then they die. Now, I will never underestimate that they are medically complex most of the time. And this is a big commitment for any family. So once again, no browbeating, no guilt. This is about walking with people to do what they can for as long as they can, and as long as this child is with them. But the parents, the moms, they do so much better when they are not invited to be complicit in their child's demise. Once again, I get out of God's way. That's who's in charge of this. I don't decide life and death. I don't have my parents make life or death decisions. That horrible euphemism of, are we going to unplug the baby? Babies don't come with outlets. I've checked. There's no extension cord. But we sometimes do need to get out of the way so that I'm not prolonging suffering. That's absolutely, and I have very honest conversations with families going, okay, this is now at a point where we need to worry about that. But most of the time it's about, how do I make sure they don't feel abandoned and walk with them?
Dr. Calhoun, do you have a favorite story of a family that walked through perinatal hospice?
That's a good question. I'm got a couple of them actually. I think the one that's probably was the most impactful was before all this came about. When I was in the military, I had a couple that, we didn't do terminations in the military, and that they wanted to go through the pregnancy and do things. And it was a small little boy who had a trisomy 13, but multiple anomalies, cardiac, heart stuff, and all sorts of different things. And just was not, no matter what we did, really wasn't going to do well. And we still were in the infancy of this whole idea of palliative care. And they had two children as well that were a little bit, I think 6 and 8, and that they wanted to go through and have the birth and do all this. And of course, I'd never heard of that, obviously. I mean, it was one of those things that we weren't taught and wasn't available. This is back in the mid 90s, maybe. And so went through the whole pregnancy and went through the delivery, and we didn't let children in deliveries at that time. I mean, how long ago was barely let dads in. So we decided we would let the children be there as well, which was, that in itself was a major accomplishment in my opinion, but it was something else. So we did that, and they had named him. We talked about, what's your child's name, and it was Jonathan. And we had this delivery, and we had Jonathan there, and he delivered a little bit early, I think about 35 or 36 weeks. But Jonathan actually looked very, very normal, if you will, because most of his were internal issues. And the whole idea was the family holding him and doing that. And at that point, I realized that that's the way it should be, that we should do that this way, that all this other, the things we were doing to hide this and to try to, separate people, and thinking how this was a very traumatic experience, we should just, not allow all this to happen with the families. I thought that was really just a very enlightening moment for me. It's like, aha, that's an aha moment. Wow, this is why we should do this. This is why it should be. And from that, moving on, began to develop with others the idea that we should walk alongside and encourage the families and parents to just be parents and love their children with their families. And I think that for me was the one thing that just started pushing me along that journey. And it wasn't for a few years later till we started developed and started building more structure into it. But that was a huge step, I think, for me to be allowed to participate in that delivery and to be able to be involved in that. That I think was a big one for me. That's what I remember most.
So,
yeah, as you both know, there are times when doctors are pro-life doctors, except for this issue. They still feel that termination or early induction hospital terminations for prenatal diagnosis should be something that's done, or at the very least given as an option. They feel some kind of ethical obligation to give women, quote, all their options or something, and be willing to refer for this. What is your response to that trend, and just for really great pro-life people that don't understand alternatives?
So this is really a problem with informed consent. If you really want to offer someone everything, then you don't offer a termination before you have the neonatologist have an opportunity to speak to the family. The amount of, oh, we don't need to bother those neonatologists. You're too busy up caring for babies. I'm like, what? Whoa. Yes, we do. I would be delighted to come and care for this little one also. So I think it's all, if this idea that the termination is an emergent decision is something that has grown and taken on a life of its own, and it's not true. What the baby's doing just fine, usually, and honestly, usually so is mom. So she was doing fine until we just gave her a fetal diagnosis that was a problem. So now, how about we slow down and get other voices in the room that are going to speak for the baby, honestly, as well as mom. So I would, for everyone saying, have you talked to a neonatologist or even a pediatrician, depending on who's available, to be able to say, let's see how this goes, or at the very least, there's reasons to be worried here, but there's a lot we can do. There's a lot I don't know because we haven't met this little person yet. So perhaps let's see what can be done. And once again, if the baby's going to have a demise because they think it's that bad, it's actually healthier for mom from a hormonal standpoint. It's very different, her hormones, if you interrupt the pregnancy abruptly, as opposed to if there's a demise. It's very interesting that the moms actually stay much safer in the long term, both from a hormone standpoint, instrumenting standpoint, all the other things that go with that. So if you really want to quote, use the words of the cycle of death, say, okay, if you want to offer all the choices, how about get someone who can speak up for the baby, to also enter into the conversation. You might, they might still choose, whatever they want to, that's fine. But under genuine informed consent, you get someone else to also enter the conversation with them.
Well, I think that you've made a really good point. I think, and there's this, you talked a lot about humility, and I mean, because I do prenatal diagnosis as well, you're talking areas of black and white, and you're talking about things that are a lot of times are not as clear as everybody they think they would like to make them medically. And I've been fooled more than once, and I'm very, like you said, very conservative involving my neonatologist because I may think I have a diagnosis, but I may be wrong. And if the worst thing I can do is to deliver a child who has a medical issue prematurely. I mean, there's no,
Right.
that's just a bad, I mean, I know that's bad. That's statistically, medically, that's bad. So why am I going to do that? And why would I deliver them a place where there's not the care that might be available if I happen to be wrong in my diagnosis? I think the second thing about this, like you pointed out, from a medical standpoint, if I truly believe, which I do, that it's not good for mothers to terminate their pregnancies and participate actively in the death of their child, I would never recommend them to do that because I find that to be medically irresponsible as part of my informed consent. The final thing that we look at, if you look at particularly deliveries below 32 to 34 weeks, particularly in first pregnancy, the risk of breast cancer, now I know everybody's going to argue, but it's in the literature everywhere. It's across all boundaries now, multiple different studies and all across the world. Below 32 weeks increases your risk of breast cancer pretty much 2 to 3 times at least. And if you're in certain families, much higher than that. So you really should let the mother go as far as she could to try to get development of the breast and maturation to prevent the breast cancer. We do know that. We also know that if you look at all-cause mortality rates for people with abortion in really well-done studies, no matter when the abortions are done, those women have a much higher risk for all-cause mortality and an increased risk of death throughout their lifetime, double to triple. So if you're thinking about informed consent as an informed physician, the best thing for the mom and the family is to have her child. It's not to terminate early or to do early inductions or to cause them to participate in the death of their child, because that's not in their best interest medically. Also, like I said, I'm humble enough to say, I've been wrong before, and I do not want to be wrong in the wrong place and to put somebody in a position now where I've really not done my job and said, oh, I'm certain of this when I'm not. It's black and white ultrasound. It's black and white. It's very, very difficult sometimes to tell. And I think you should be humble enough to say, yeah, I just don't know for sure. And involve my
yeah, I think we have to be honest with people, with young families, with people who are, just starting out their married lives, about the reality of prenatal testing is prenatal testing. I mean, I love becoming prepared to a delivery. So, but on the other hand, I've just seen it in biased hands become probably today one of the biggest barriers to perinatal palliative care because the baby doesn't make it. I actually saw a study out of New York, I know, big surprise, that when the latest prenatal testing, which can be done with pre-cell DNA, so just a blood test for the mom, it can be done as early as 10 weeks. They actually quizzed the parents. They hand out, a survey first and said, "Are you open to termination? Because then we really want to get you this test." I'm like, "Oh my gosh, this is just not even pretending. And what really worries me is, did they even get a fetal ultrasound? Did they wait long enough to confirm a test that the percentages maybe 40 to 60%, right? I mean, and they even, right, they even admitted that they probably have, terminated totally fine babies. And I'm like, oh my goodness.
What really bothers me is that, again, the ethical underpinnings, you've talked a lot about this. The ethical underpinnings of this are actually are evil. Machiavellian, if you will. They are eugenics. Okay, we're going to take somebody who we think might be a problem, and we're going to get rid of them. Of course, the other part of this is that nobody, even my residents, I talk to them. Where do those cells come from in that diagnosis? They come from the placenta. They don't come from the baby, right? And I said, you know how much time the placenta has mosaicism in it? It's huge. It's 25% or more, maybe, of the cells are not normal in a normal placenta, quote unquote. And so it's shedding all these cells that are abnormal that are not even from the baby. They're from the placenta. And you try to explain this to even the residents, physicians in training, and their eyes glaze over. I go, it's very difficult to try to, and once the train's left the station, it's very difficult to get it back because they're not informed. They say, here, can you get this blood test? What they really want, this is terrible. What they really want to know is the sex of their baby. They don't care about any of the other stuff. If you ask them, why are you getting this test? Oh, so I get a gender reveal and get the sex of my baby. I go, that's not the reason this is being done. Please don't do that. You may regret this. Why don't you just wait till 18 weeks? I can tell you all the anatomy, you can tell it's a boy or girl, and it's not that much later. And let's just do that versus if that's all you want, maybe that's not the thing we should be doing. That's not the test for this probably. And it's just eugenics, pure and simple for the most part. Evil.
And it's so problematic. I once, I had a family that actually said in so many words, if you can't guarantee us the baby is fine, I don't make those guarantees at term. And so I was just, I was stunned. What do you mean guarantee? No, there's not a return thing either. I mean, I've looked, so it's just, it's astonishing. We really are a culture of expediency. And if it's imperfect, we get rid of it and we go to Best Buy or wherever else, you click Amazon and get a new one. We're talking about a child who has intrinsic value. I actually had to have an argument with an obstetrician who was like, oh my gosh, you're using the word child and how wrong that is, and you're forcing this conversation on this parent. And I'm like, whoa, how about, why isn't it a child? They started to try to tell me that, embryology isn't science. And I'm like, oh, okay. So we're going to go back to Hippocrates and Aristotle, and then flip forward to the 1600s when Leeuwenhoek first saw the sperm under a microscope. By the way, they got that wrong. They thought the whole baby was formed and then kind of poof, blew up in once it was implanted. But I'm like, we stand on the shoulders of scientific giants. And we have had the privilege literally embryology is ancient. And we've learned that, hey, we didn't have it quite right. So let's keep working at this until we have this figured out, as opposed to claiming there's consensus that we for sure know what's going on. The latest today is fetal pain. Oh, that can't be true. Sports fans, I mean, ask any parent in the room, or any parent who's been in the NICU, who's had a 22-weeker. Yeah, I can tell you, they hurt. And by the way, I've been smacked by little tiny 22-week hands. They hate having their temperature taken. I don't know why that makes them lose their minds, but it does. That yes, fetal pain exists. We used to have this idea that you had to have something called cortical connections, which don't develop until 24 weeks. There's now many studies that are talking about subcortical pain. It is so involved, and there's something called a subplate, which is a fetal structure which dissolves over the first 3 years of life, we don't know what we don't know. But we also have now evidence that when we treat pain or ameliorate it or try to change the neonatal environment so they don't have that, they survive better. We decrease by actual statistical value all of the complications of preemiehood. So yeah, fetal pain is legit, and there's studies that show that it is. And by the way, we've changed medical practice because of this. We used to take babies to surgery as recently as 1992, when Dr. Anand and company had their study comparing babies who had cardiac surgery with and without anesthesia. Here's a surprise: the babies without anesthesia didn't do well. We changed once again. Even though, by the way, that was consensus back then, not that long ago, that babies didn't feel pain, we were wrong. Consensus is overrated. What we need to do is continue to work at the science and look at what's clinically and just theoretically appropriate to then match this with, is that what the science is saying? Because if something's amiss, maybe we need to go back and look again. And, you know, the only groups that are in consensus that fetal pain doesn't exist are those that are defending terminating earlier. So anesthesiologists and neonatologists treat their baby's pain. It kind of tells you something about the outcomes.
Well, just in our last minute here, would y'all speak to prenataldiagnosis.org and how it's really bringing together the different specialties of the different types of prenatal diagnoses, that we can have perinatal hospice resources and NICU resources, both your expertise. I know you both contributed to that website. And if you have any other favorite resources, I just wanted to give you a chance to talk about that.
Be Not Afraid. And also, if people would like to find me, the American College of Pediatricians, ACPEDS, has a website. So I can be located there, as well as Tracy Windsor at Be Not Afraid reaches out to me to help with her. So I can be found through all those sources.
Yeah, the other one that's an organization that works with the obstetrical side is the American Association of Pro-Life Obstetricians and Gynecologists, or APLOG. They do a lot with pro-life obstetricians and other pro-life workers that are available, healthcare workers who are in that organization as well. So that's APLOG, AAPLOG.org is a good resource. It has a lot of resources there as well. So I would encourage people to have other medical questions, in particular on the obstetrical side. That's a great source for both personnel and physicians, providers, and also for a lot of different information as well.
Beautiful. Thank you both so much. Thank you all for coming. We look forward to next month with you all. We're going to have some prayer to end our year for the month of December. And thank you both. And I'll just close this in prayer now. Lord, we just bless these doctors. We bless their work, and we ask that their influence go far and wide, and that many people would come to know the beauty and power of treasuring every life through them. In your name we pray. Amen. Thank you all.
Thanks.
Thank you.